It's time for the 3-question warm-up for Foundations 9. Let's get going. What is the underlying dysfunction in Chidiac-Higashi syndrome? So this is an immunodeficiency syndrome where the lysosomes of the phagocytes are ineffective. Next question. How does having a high cholesterol content in the plasma membrane affect the function of the plasma membrane? Well, it's going to decrease fluidity and it increases melting temperatures. Next question. A patient presents with an aganglionic colon and other neural crest derivative deficiencies. What other findings would you expect to see? So basically this is asking what for other findings would you be associated with failure of those neural crest derivatives to develop properly. So in addition to this aganglionic colon, which is a developmental problem of the enteric nervous system, you could also see peripheral nervous system abnormalities, also autonomic dysfunction. You might see conductive hearing loss because of the ossicles of the ear don't form. You could see anterior chamber eye problems. You might see dental abnormalities because the odontoblasts arise from the neural crest as well. You might see albinism because the melanocytes actually arise from the neural crest as well. And finally, you might see heart defects like a truncus arteriosus or transposition of the great vessels due to failure of the aorticopulmonary septum from forming correctly. All right, guys, that's it for the 3-question warm-up. Let's get to that video.
This is the last of the Foundations videos, and before we move on to neurology and start getting into a more organ systems-based approach, we need to talk about how cells adapt to injury in stressful environments. So in the video on inflammation, we talked about tissue responses. Now we're going to be looking at a more cellular level. We're going to see that cells can either become stronger to withstand further injury, or cells can be replaced by new cells. And then we'll also look at what happens when cells are irreversibly damaged. We'll also look at cells in the give-up stage, when instead of fighting back, they just sort of wimp out and atrophy. Now, I'm sure you've heard the phrase, anything that doesn't kill you only makes you stronger, right? Well, how can cells and tissues become stronger in the face of injury? They can either undergo hypertrophy or hyperplasia. Now, a lot of this material we're going to go over is found in Robbins pathology, which you should definitely be familiar with for your test. Really the first 7 chapters of Robbins. It's very high yield, basic, fundamental knowledge. I wouldn't necessarily recommend that you try to read all that at this point, but you might at least flip through it, make sure you understand the images and diagrams in bold terms. They tend to put the key summary sentences in italics, which makes it really easy to go through and highlight the really important concepts in Robbins. So, in the face of damage and injury, cells can either adapt and become hypertrophied or they can undergo hyperplasia. Now, this is really basic, but hypertrophy means the individual cells get larger, and as a result, the whole organ gets larger. So if you exercise and work a muscle, that muscle will respond by laying down more myofibrils, which makes the individual muscle fiber stronger, but it also makes the entire muscle bigger. So in general, hypertrophy occurs due to the production of more cellular proteins. Another example would be hypertrophy of the uterine muscle, or myometrium, during pregnancy. Now, part of the reason the uterus gets enormous is you're putting a baby in there and stretching it out, but most of that happens late in pregnancy. Much earlier on in pregnancy, hormone changes cause the uterus to lay down myofibrils and the cells become hypertrophied. And it's important to be able to strengthen that muscle for when it has to push out the baby. But here, the stimulus isn't exercise, the stimulus is hormone-induced hypertrophy. Now, unfortunately, hypertrophy is not always a beneficial adaptation. One good example that we're going to see again in cardiology is myocardial hypertrophy. There are several reasons for the heart myofibrils to be enlarged and increased and hypertrophied, but the most common reason for cardiac hypertrophy would be chronic hypertension, where the afterload is increased, and the left ventricle has to work harder to push the blood against that increased afterload, and those myocardial cells hypertrophy. But instead of making the heart stronger, mostly what it does is make the ventricle stiffer and less compliant. And one of the things that happens is that the ventricle can't relax, it can't fill as well, so left ventricular hypertrophy leads to diastolic heart failure. So hypertrophy may be a maladaptive, self-defeating process in certain situations. Then the flip side of hypertrophy is hyperplasia. Instead of having bigger cells, with hyperplasia you just have more cells. And again, when you grow more cells, the overall organ can get bigger. Again, these changes can be triggered by hormones. For instance, during puberty, young women start producing estrogen, which causes development and hyperplasia of glandular tissue of the breast, and as a result, the entire organ gets larger. Estrogen also causes proliferation of the endometrium as part of the menstrual cycle. Then if you give estrogen to a menopausal woman and you never withdraw that estrogen so that the endometrial lining is shed, that's a form of endometrial hyperplasia, and you're at increased risk of endometrial cancer. So hyperplasia itself is not necessarily cancer, but it can progress from hyperplasia to dysplasia to cancer under the right circumstances. So some cellular stressors trigger hypertrophy and hyperplasia. But what happens if the cells are stressed and injured to the point that they die? How can we replace them? Well, sometimes we can't, but sometimes we can. This brings us to stem cells. Now, stem cells are definitely a hot topic in the public sector as people worry about the ethical issues of harvesting stem cells from embryos and such. So what is a stem cell? Basically, a stem cell is a cell that can renew itself again and again and again. And then some of the daughter cells can differentiate into specific cell types, while other daughter cells retain this ability to self-renew. So a stem cell is able to divide into a precursor cell that goes on to be a new cell, whatever cell is needed, then the other cell is still a stem cell. So think back to the zygote, one cell. Or maybe a little while later, say you've got 8 cells. If you were to split that zygote in 2, would that zygote develop into half a person? No, those cells are essentially undifferentiated stem cells. They can keep dividing and they can eventually turn into anything. That's why when the zygote splits, if both cell masses survive and keep dividing and growing, you get identical twins. So at that early stage, every cell has the ability to grow into an entire organism. Now, fast forward a week and you've got a blastocyst. You have a hollow ball of cells with an inner cell mass. Not very many cells overall, maybe 100. Those cells in the inner cell mass aren't terribly differentiated yet. They still have the capacity to become any tissue in that fetus. They're called embryonic stem cells. They haven't committed to any particular cell lineage. Now, at some point, those cells do become committed. They're still stem cells that are going to divide and make a lot of different tissues, but they're committed to being endoderm-derived tissues or ectoderm-derived tissues and so on. Now, eventually, we have stem cells that are committed to being neural cells or blood cells or whatever the case may be. So think about your bone marrow. It has to be able to make new cells constantly, right? I mean, leukocytes are constantly getting used up fighting infections and fighting foreign invaders. And red cells only last about 120 days under the best of circumstances. So in your bone marrow, you have pluripotent hematopoietic stem cells. Again, they're pluripotent, so they have the potential to become many different cell types. But they're hematopoietic cells, so no matter what they become, it's going to be a blood cell of one type or another. They can't go become liver cells or neural cells because they're partially differentiated, but they still retain some stem cell abilities. So here's your pluripotent hematopoietic stem cell, and it's receiving a stimulatory signal from the body that says, we need lymphocytes. So this stem cell can grow and divide, and one of those daughter cells is going to differentiate into a lymphoid precursor cell, and it's irrevocably committed to becoming a lymphoid cell. Whether it's a B lymphocyte or a T lymphocyte or a natural killer cell hasn't been decided, but it's committed to being a lymphoid cell. But this daughter cell over here is going to somehow retain its pluripotent self-renewing properties. So instead of becoming a lymphoid cell or whatever, it's going to just grow and divide again and again and again. That's what makes these stem cells special. Then the other interesting thing about stem cells is that we've discovered that if you take an oocyte and you remove the nucleus and you stick in the nucleus of any old mature differentiated cell, you can turn that oocyte into an embryonic stem cell with the donor cell's DNA. And then you can culture that and get it to differentiate into pretty much whatever tissue you want. That's how they've been able to clone sheep and cats and water buffalo and camels and all sorts of things. This is still a long, long way from being practical, but it's pretty interesting to think about being able to one day grow new organs for transplant or to grow new pancreatic beta cells for kids with type 1 diabetes or whatever. So it's a very hot topic of research. So one of the big attractions of the stem cells technology is to be able to regrow a brand new organ and replace one that's worn out or diseased. But there's one organ that already has a tremendous capacity to regenerate itself, and that's the liver, sort of. I say sort of because the liver doesn't exactly replicate itself like a lizard regrowing a tail that fell off. If you surgically resect, say, the entire left lobe of the liver, the right lobe of the liver is going to undergo a massive amount of compensatory hyperplasia. So the right lobe is going to grow and grow and grow until it's basically the size of the original liver. But it isn't really a complete regeneration because anatomically it's still very much a right lobe. It's just massively enlarged. But because it has grown so much, you have the same synthetic and metabolic capacity as a whole, healthy liver, which is important because the liver is necessary for energy metabolism and storage, protein synthesis, toxin and drug processing, a lot of crucial things. So having a liver that's large enough to do all those things is extremely valuable. But the really interesting thing about this is that the liver doesn't regrow from hepatic stem cells. It's not regrowing from stem cells that are recruited from the bone marrow. What actually happens is that quiescent hepatocytes are sort of awoken from their slumber and they come out of the G0 phase of the cell cycle and they actively divide once or maybe twice, and then they go quiescent again. And then not only are the hepatocytes dividing, but also the support cells and the endothelial cells and the Kupffer cells are also dividing. So there are a bunch of cytokines and growth factors that are somehow able to trigger something really unique in the liver and make this happen. What's the secret? How do we harness this power? Another way that cells can adapt in response to injury is called metaplasia. Now, metaplasia is a reversible change when one cell type is replaced by another cell type in response to some kind of ongoing stressor. Now, there are lots of common examples of this. For instance, in smokers, we see the normal epithelium of the trachea and the bronchi, which is supposed to be ciliated columnar cells. That normal columnar epithelium is replaced by squamous epithelium because the columnar epithelium is very sensitive, very delicate. That squamous epithelium is more rugged and tougher, and it can handle the exposure to smoke and toxins. But there are a couple of potential downsides to this. First of all, there's a reason we have that ciliated epithelium in the first place, to produce mucus and fight off infections. So when you replace that with squamous epithelium, you're going to have less mucus production. You're more likely to have respiratory infections. The second downside is that these metaplastic cells are set up for transformation to cancer. Another form of metaplasia you should be familiar with is called Barrett esophagus or Barrett metaplasia. This is where the normal squamous epithelium in the lower esophagus is replaced by columnar epithelium, which is similar to the epithelium seen in the intestine. So this is sometimes also called intestinal metaplasia. And what's the injury that causes Barrett's esophagus? Chronic gastroesophageal reflux. And again, this is important because Barrett's esophagus is a precursor to esophageal cancer, specifically adenocarcinoma, which is the most common type of esophageal cancer in the U.S. So what causes metaplasia? Are you somehow changing differentiated squamous cells into a totally different cell type? No, that'd be somehow like making a hepatocyte turn into a neuron. What's going on with metaplasia is that local stem cells are being induced to make a new cell type, though the exact mechanisms aren't really understood. So let's move on to another pathologic phenomenon we need to discuss, which is atrophy. Now, you know what atrophy is, right? It's shrinking, right? You either reduce the size of individual cells or you reduce the number of cells in a given tissue. So it's the opposite of both hypertrophy and hyperplasia. We often talk about muscle atrophy from disuse. Like if you break an arm and you're in a huge cast for 6 weeks, what's that muscle going to be like when you get the cast off? It's going to be weak and shrunken and atrophied, right? There are lots of different things that cause that atrophy. Decreased hormone signals, like when a woman goes through menopause and she's not making estrogen, she's going to have atrophic vaginitis, where the tissue gets very thin and dry and more easily irritated. You might have atrophy from decreased innervation. So if you have a spinal cord injury or some peripheral nerve injury, that muscle is going to atrophy and it's going to get a lot smaller. Decreased supply of oxygen and nutrients can cause atrophy, maybe through decreased blood flow or hypoxemia from lung disease, or if you have decreased nutrients from malabsorption and malnutrition. All those things can cause tissue atrophy because you can't maintain the size of the tissue. Increased hydrostatic pressure can cause atrophy from tissue compression, or if there are kidney stones and urinary obstruction, and that can lead to renal atrophy because there's physical pressure on the kidney tissues. So we also see this with occlusion of the secretory ducts, like with cystic fibrosis, which can cause some atrophy as well. So what's going on at the cellular level with atrophy? Well, first of all, there's reduced metabolic activity, and there are fewer cell organelles. There's reduced metabolic activity that leads to less protein synthesis. Not only is there less protein synthesis, but the proteins that are already there are getting degraded, usually by the ubiquitin proteasome pathway. So when there's disuse, there's nutrient deficiency, the cell starts to attach that protein ubiquitin to its other proteins, and then those other proteins get dismantled by the proteasomes. And then just like a starving person will begin to digest his or her own muscle for energy when they get muscle wasting, a starving, nutrient-deprived cell is going to start eating its own organelles and its own components in a desperate attempt to survive. And this process is called autophagy, which means self-eating. Then as part of this autophagy process, you've got free radicals that are oxidizing things. When you have oxidation of lipids, it results in a yellow-brown pigment that's called lipofuscin that doesn't get completely digested and cleared. So you can see these atrophied cells that fill up with these little cytoplasmic vacuoles full of this brown lipofuscin, and those are called lipofuscin granules. The last major change that the cell can undergo is senescence, or aging. We said atrophy occurs due to some extrinsic insult that cuts off nutrients, and since the cell just isn't able to fight back, it's going to sort of shrink and shrivel up. But what about a cell that has plenty of nutrients? There's no trauma or toxins or injury. I mean, why don't those cells live forever? It's one thing to say, well, everything wears out sooner or later, but why does it wear out? A cell has all this great cellular machinery to make all the proteins and lipids and everything it needs as long as it has the nutrients it needs, right? So in the presence of adequate nutrients, why won't cells live forever? Well, for starters, cells seem to have a fixed number of times that they can divide before they just quit. I mean, even cells in culture, with everything they need to go on forever, it's like they have a counter, and once they reach their limit, they just quit dividing. The culprit here is that on the ends of our chromosomes, we have the long, non-coding DNA sequences that are called telomeres. And every time the cell divides, those telomeres get clipped just a little bit. So with every round of mitosis, those telomeres are going to get a little bit shorter. Basically, the shorter the telomeres, the older the DNA, and the older the cell. It's kind of like counting the rings on a tree, only in reverse. So shorter telomeres means an older cell. So once the telomeres get to some minimal length, that cell just won't undergo mitosis anymore. It sort of shuts down, the cell gets senescent and age, and then eventually the apoptotic pathways are activated. Now, there's an enzyme called telomerase that's supposed to elongate those telomeres. So germ cells have a ton of telomerase. Stem cells have a little telomerase. But in mature somatic tissues, there's virtually no telomerase. So as those cells divide, the telomeres are gradually getting shorter and shorter. But here's an interesting thing. One of the things that cancer cells do that makes them cancer cells is they figure out how to start expressing telomerase again so that they keep their telomeres nice and long. And that basically makes cancer cells immortal. We're going to talk about that again when we get to the oncology section. Then one last thing I want to throw in here about cellular aging is that the most effective way we know of to prolong your lifespan is calorie restriction. It doesn't matter if you're a tiny single-celled yeast or an enormous blue whale or anything in between. If you restrict caloric intake, your cells are going to live longer on average. So on that note, let's go get a snack. But first, let's do the end of session quiz. So pause the video and answer those questions, and then we'll go through the answers together. All right, let's go through these answers. First question, does the compensatory growth of muscle fibers occur primarily as a result of hyperplasia or hypertrophy? Well, it's hypertrophy. Next, does myometrial growth in pregnancy occur primarily as a result of hyperplasia or hypertrophy? Well, again, that's hypertrophy. Next, what can happen to the cells of the lower esophagus in response to chronic acid reflux? They can undergo metaplasia from squamous epithelium to columnar epithelium, which is known as Barrett esophagus. Next, what's actually occurring at the cellular level during atrophy? So reduction in the number of organelles, decreased protein synthesis, increased protein degradation, usually by that ubiquitin proteasome pathway. You have autophagy or self-eating as the cell begins to digest its own components in an attempt to find nutrients and survive. And finally, there's free radical oxidation of cellular components. And the last question, what's a lipofuscin granule? It's a residual body within the cell that contains that yellow-brown lipofuscin pigment that comes from free radical-induced lipid oxidation. All right, that's it for Foundations 9. I'll see you soon.